Thank you. So Peyronie's disease, how are we doing in terms of the guidelines in the UK? One of the problems, as you probably all well know, with Peyronie's disease is, in terms of comparing it, looking at treatments and comparing studies, is the natural history of the problem. It's an evolving condition, it changes, and of course it depends exactly on which time point you see the patients as to what will happen to them in the subsequent 6 months or a year. There's also problems in comparing studies, in that some studies will have a mean presentation time of, let's say, 6 months, others might be 9 months, so your subsequent natural history will depend on when patients are being seen. And also there's lots of studies out there with no placebo arm, maybe comparing one oral therapy versus the other, and the all-important placebo is missing. And just to remind you of the natural history, here's a recent paper looking at 176 men with a mean curvature of 42 degrees, presenting at an average of 9 months presentation, and about 12% of them improve in the subsequent year, and approximately 20% of them are going to get worse in the subsequent year. So we have to bear that in mind at all times when we're treating this condition. So back to the guidelines. So what I've done is I've looked at primarily the European guidelines as they pertain to us most appropriately, and then also some more recent AUA guidelines. Also looked at some of the UK activity. HES is not particularly good at capturing Peyronie's disease. The diagnostic code, that is, it's termed indurato plastica penis, and I don't think any of the coders know what that is. So there were 5 cases of Peyronie's in the UK last year, according to HES. And we know that's not the case. With the procedures code, that's slightly better, and I think that's probably a bit, if you look at the over 18s, there were 735 corporal plications last year, which probably is a bit more accurate, but yes, we've got to be careful when we're looking at HES figures. And then graft to the penis, some of those obviously will be incisions and grafting for Peyronie's disease, some of them may not be, some of them may be grafting for other reasons. The other thing that's recorded and has its own code on HES is the shockwave therapy, and as you can see there's still some 500 cases of shockwave therapy to the penis going on in the UK in the last year, although some of those may be for erectile dysfunction. The other thing of interest, you can get lots of data from HES, and again, caution with these figures, but we can look at readmission rate, length of stay, etc. And there's an interesting graph here showing length of stay is inversely proportional to the volume of corporal plications taking place, and it just tends to take off at around about 20 cases a year. And that maybe is of interest as we move into the future. So what have I done? So I've polled 16 what I perceived as being reasonably regular Peyronie's specialists or urologists in the UK, higher volume surgeons, who very kindly got back to me very promptly on a short time scale with the answers to 10 pertinent questions, and those questions were in the area of how do you evaluate Peyronie's disease, what medical therapies do you use, what mechanical and injectable therapies do you use, and how do you tackle the area of surgery. So first of all, in evaluating patients with Peyronie's, the guidelines, these are the European guidelines, probably state the obvious. We've got to take a history and examine the patient. So you need to examine the lesion, make sure it's not anything other than Peyronie's disease. But they also make reference to making sure you measure the penile length, and recording that for obvious reasons. Not only does the condition affect it, but the treatment can affect it. The patient's perception is often an exaggerated one, and men who often have treatment will perceive that the shortening is actually greater than what the objective measurements are. So from a medical legal point of view as well, it's advisable, according to the guidelines, to document that. Then in terms of assessing the curvature, I know there's mixed opinions on whether you do a drawing or take photographs or do an intracavernosal injection, but in the EU guidelines self-photography is an acceptable method. They advise against ultrasound of the lesion, doesn't really add anything, but they do mention that duplex ultrasound is appropriate and indicated in men with Peyronie's disease and erectile dysfunction. In the American guidelines, they talk about doing an intracavernosal injection in the clinic with or without Doppler ultrasound. So what did we do in the UK? Well, not so good with this one. 7 people out of 16 routinely measuring penile length, 6 not at all, and then 2 people using it discretionary, depending on whether they feel there's problems ahead. Certainly the men presenting, for instance, wanting a Lou procedure where they don't really need one, raise suspicions because they're maybe overly concerned about penile length. And another colleague of ours only measuring it if they feel the penis is short. In terms of how do we routinely assess the curvature, this is pretty standard, I think, in the UK, by the looks of it. So 13 out of 16 using photography, usually 1 from above, 1 from the side, and then record. What I do is I look at the pictures and draw into the notes so that there's a record in the notes. And 2 people routinely using injection therapy, but clearly that's a little bit more resource heavy and a bit more painful. You do sometimes photos are not satisfactory. You've got to make sure that the patient's got a full erection at the time. You may want to ask them that. If not, and if there's doubt, I think it's probably advisable then to move on to intracavernosal injections in the clinic. Not very many people using Doppler ultrasound in the UK. Presumably that's a resource issue. Some people, 2 people using it selectively when there's erectile dysfunction, but I'm not entirely sure as to what that really adds to the decision-making process. Okay, so what about medical therapy? So in summary, no drug has been approved by the European Medical Association for the use in Peyronie's disease, and only Potaba has been classified as possibly effective by the US FDA. EAU guidelines do mention Potaba as being, the word may comes into these guidelines a lot, possibly reflecting again the natural history and the confidence levels with treatment in Peyronie's disease, but this treatment may be effective. The word may features in almost every section of the guidelines, but essentially Potaba is the only oral therapy mentioned, and they go so far as to recommend against using vitamin E and tamoxifen in the American guidelines. And again, there is no level 1 evidence that there's any medical therapy that can intervene in this condition. Some medications helping with pain. Potaba, there was in the control group, in the placebo group, there was a worsening in the curvature, whereas in the Potaba group, the treatment arm, there was it arrested the deterioration, but there wasn't actually an improvement in the curvature. And bearing in mind that most patients come along to our clinics with a curvature that they want to see improving, this is not a drug you can really say to them, this will sort your problem out. Note on pentoxifylline, which there was some data on. This has come out since the guidelines. This is a retraction statement in the BJUI earlier this year, stating some statistical irregularities with the pentoxifylline data. So that again is not really something with a strong evidence base. So what do we do in the UK? Well, again, quite a bit of variation. 7 people using vitamin E regularly, 4 offering no medical therapy, 2 clinicians using Potaba, plus a few others using that as second line to vitamin E, a couple using phosphodiesterase inhibitors, although as we know, a lot of these patients have got erectile dysfunction anyway, and 1 using a combination of tamoxifen and pentoxifylline. What about injectable and mechanical therapies? Well, the EAU guidelines state that there's some grade C and B evidence in favour of verapamil and collagenase and interferon injections, as well as traction and vacuum therapy, again, may help. In the UK, nobody's using, none of the 16 people I asked is using verapamil or interferon injections. 9, so the popular answer here was a vacuum erection device. That's obviously gained a lot of ground the last few years. It's cheap. There are no side effects in particular, particularly when it's used as an exercise for short periods. 4 people not offering any treatment at all along these lines. 2 people using a penile extender, which has to be applied for many hours a day. Not sure how practical that is. And 1 so far using a combination of collagenase and vacuum erection device therapy. A word on collagenase. I think you saw this slide or a variation of it this morning. I suppose there's a new kid on the block, the IMPRESS study, looking at a protocol of 8 injections of collagenase or Xiapex into the plaque, sort of 4 pairs of injections followed by moulding or stretching of the plaque and then moulding by the patient. And at the end of all of that, they mean improvement in curvature of 17 degrees. So we'll see where that goes, but as you heard this morning again, it's more effective in the milder end of the scale in terms of curvatures. So shockwave therapy, the guidelines, the European guidelines and the American guidelines warn against using shockwave therapy for treating penile curvatures. There may be room for using it in pain, but not for the curvature. It's an ineffective therapy. And I'm glad to tell you that 12 people are not offering it at all of the 16 polled, and 2 are offering it only where there's intractable pain. And therefore that raises the question, why are we picking up 500 cases of this treatment on HES? I think maybe there are some units still using this for Peyronie's disease, but essentially it's a waste of money if you look at the data. And maybe some people are using it for erectile dysfunction because that's something that's been pushed from a commercial point of view recently. What about timing of surgery? So if these patients need an operation, when do you operate on them? The EU guidelines say that you should either have stability for 3 months, stability in terms of the curvature, or they should be 1 year since the onset of their symptoms. The AUA merely state that the presence of stable disease, which is a little bit more vague. So how do we do on this front? Well, 5 people sticking to the 1 year cutoff, including myself. 3 people using a slightly longer cutoff of 18 months. A couple using 9 months. Certainly in NHS, with a 3 or 4 month waiting list. I think what I actually do is see them at 9 months, put them on the list, by which time the operation comes round, they will have done their year. But remember that if you see them at 9 months, like the study I showed you earlier, a proportion will progress subsequently, therefore altering your outcomes from surgery potentially. Some people using 3 months of stability, 6 months of stability, 5 months, and 1 just operating when the patient thinks that things are stable and the pain has gone. So quite a bit of variation there. In terms of choice of operation, when do we do a shortening or a Nesbitt procedure, and when do we do a Lou procedure? I think that's one of the bigger questions for us as surgeons. The guidelines are relatively clear to use a 60-degree cutoff, and if you're going to do a shortening procedure, then they have to have adequate length to lose a couple of centimetres. And obviously they should not have any special deformities like hourglass deformities, waist deformities, etc. When do you graft patients? Well, you're probably all aware they need to have tip-top erectile function for a start, and on top of that a severe curvature of over 60 degrees, no adequate penile length possibly, and complex deformities, again if they've got good erectile function. What are we doing in the UK? Well, in terms of going back a second slide again, in terms of the guidelines, it says here interestingly especially plication techniques for the Nesbitt procedure, but it doesn't go any further than that in terms of comparing things. But essentially, the majority are using a traditional Nesbitt excision. 4 are plicating. 3, doing a variation on the Nesbitt procedure, either removing part of the thickness of the tunica or drawing a couple of parallel lines and burying the tunica. And 2 people are using the 16-dot Lou technique, which is again a type of plication. In terms of who or when do we do grafting procedures, a bit of a spread here in the answers as well. 5 people using the 60-degree cutoff, 5 people not really. In fact, 9 out of the 16 people I asked don't routinely offer incision and grafting. Interestingly, some people are sort of more tailoring it to the patient, particularly around their anxieties regarding length, etc. And of course, some people just quoted that they would be interested in looking at the erectile function, and then others looking at the residual length. So if you're going to do a Nesbitt procedure, if that leads to a particularly short penis, then they would think about a Lou procedure instead. What types of grafts are we using? Again, a spread. Some using bovine pericardium, pelvical, vein, biocore, which is the porcine heart valve material. But again, no real consistency there, except to say that vein seems to be going out of fashion a little bit, whereas many years ago, I think most people were using vein. In terms of penile implants, it's quite clear really that the indications for prostheses in Peyronie's disease are in those men who have erectile dysfunction, particularly erectile dysfunction that's resistant to oral or simple therapies. And both sets of guidelines are fairly consistent on that. And as are UK urologists, I think most people recognise that implants are indicated where the ED is severe or where there is a severe deformity. Also, if there's previous surgery that's failed, so for instance, you've done a Nesbitt procedure and they've now got erectile dysfunction and perhaps some more scar tissue, that further tunical operations are probably hiding to nothing. And then the other problem, of course, we've got in the UK at the moment is funding for these implants. Hopefully will change in years to come. So in summary, what we're good at is that we are particularly good at, in terms of abiding with the EAU guidelines in assessing the curvature in the appropriate use of investigations using mechanical devices. We're no longer using shock waves. We're pretty familiar with the cutoffs for when to do which operation. But there's probably room for improvement in that we all need to be probably recording and measuring the penile length and writing it in the notes. We are not particularly consistent or evidence-based when it comes to the medical therapy of Peyronie's disease. We're not using many injectable agents, but that may change. We've all got slightly variable cutoffs for surgery, and it's probably the guidelines are quite clear that either 3 months or 1 year since the onset of symptoms. And there's also a variation in the types of operations we do, although that's not stipulated clearly in the guidelines. So food for thought.